Hi, I would like to start this pharmacokinetics tutorial. I believe that this series of tutorials will help you to understand this topic clearly and have a sound pharmacokinetics base. This is the fourth part of the tutorial. You can check the basics of absorption, distribution, and metabolism in the earlier part of the series for a better understanding. Listeners, there are a lot to know in the world of pharmacokinetics. The kidneys are the primary excretory system, whereas the hepatic system is the main site involved in drug metabolism. Other sites of metabolism include the gastrointestinal tract, pulmonary system, and skin. So here in this tutorial, we'll mainly focus on both the kidneys as well as the hepatic system for as a metabolism as well as for the excretion of the drug. Renal excretion of drugs is a complex phenomenon involving one or more of the following processes, be it glomerular filtration, active tubular secretion, or passive reabsorption. The glomerular filtration occurs here in the Bowman's capsule. This is the nephron of the kidney. Okay, the blood comes here and the filtration takes place. So the blood passes through the afferent arterioles, and here is the glomerular capillaries. Then after the blood passes through the efferent arterioles. So when this component of the filtration fluid the passes through the tubules, okay, active secretion or passive absorption takes place. Some essential elements were absorbed and others are excreted. Let's start with the first important topic today, that is first and the zero order kinetics. So in case of zero order elimination, the amount eliminated will be dependent on time and not the amount ingested. Whereas in case of first order kinetics, the amount eliminated will be dependent on the maximum blood plasma concentration and not on time. And the thing is that, which you may have guessed right till now, that for us, for any individuals, it is the first of the kind that is more important because if you take a lot amount of drug, similarly, the drug will be excreted because it is concentration dependent. Whereas in case of zero the kinetics drugs, if you take a lot of drugs, the drug will be accumulated inside your body because it is time dependent. Okay, we will learn more about it and try to differentiate with an example. So the fundamental difference between zero and the first order kinetics is the elimination rate compared to the total plasma concentration. So zero order kinetics undergo constant elimination regardless of the plasma concentration. Okay. So for example, take this guy. He's a bartender. Okay. He bartender making drinks in a bar. You can say he has a lot of orders. But the point is that regardless of the total amount of drinks or orders that he he get in the evening, the bartender can only prepare one drink every 1 minute. That is 60 drinks in an hour. So if he gets more than like 120 also or 180 drinks order, he will what will happen is that he can only provide 60 drinks in an hour. So rest will be stockpiling. Okay. So in that case, if you consider this to be a drug, suppose if you give a 50 milligram, can say 50 milligram drug, and the elimination at the end of 1 hour is only 25. Okay, so what amount is being there in your body? That is 25. 50 minus 25 is 25. But if you give like 100 milligram dose, or you can say 200 milligram dose, then also the elimination is only 25 milligram in the first hour. So in that case, you will have like 75 milligram here and it's like 175 milligram here. So it doesn't depend on the constant amount of drug that you are taking. It is the in case of zero order kinetics is the constant amount of drug that is being eliminated, not fractured, but constant amount of drug that is being eliminated from your body. That is how zero order kinetics works. So next about the first order kinetics. Here you can see proportionally increases elimination as the plasma concentration increases, following an exponential elimination phase as the system never achieves saturation. So what does it mean? Let's again take the example with the bartender. He was alone at the time. Now he have a lot of friends. Okay, so if he has more orders, he will bring more friends. Okay, so now if we have 120 orders, he will bring one more friend. So ultimately 60 like 60 drinks in an hour. So into 2 is equal to 120. So if you have like 180 drinks to prepare, he will add one more friend. So in that case, The more drinks they are to prepare, the more bartender can sign. The real limiting factors of this analogy and the first of the kinetics is the initial concentration. And again, if you want to understand from the number plots from the drug, like in 50 milligram, 100 milligram, 200 milligram. So in case of 50 milligram drug, if you take the drug, the 25 milligram will be excreted from the body. That is around 50% of the drug will be excreted from the body. That is the from the initial concentration. Here the constant fraction. So if you take 100 milligram of drug, then you like 50% of 100 milligram is 50 milligram will be excreted. In 200 milligram, if you take the initial concentration, 50% of 200 is 100 milligram will excreted. So in that case, a constant fraction of the drug will be excreted. In case of zero order kinetics, it is constant amount of drug that is being excreted. So that you need to remember. So, so let's take an example of an IV drug. Okay. So it is being given, and ultimately at zero time we have around 256 concentration. Okay. So this half life is around 2 hours. So at every 2 hours, the concentration of the plasma concentration will be half. So you can see here 256, 128, 64. So every two hours, the concentration will be, you can say, you can divide it by 2, okay, by making it half. So this is how the first of the kinetics moves. You can see this, if we can see in a line type of thing, we will find it a curvilinear graph, but we have to plot it in log plasma concentration. So while doing exercise also, you have to plot on the concentration of drug in the log table, okay, semi-log paper. So in that case, we'll find a very straight line. You can, you can see here the first of the concentration versus zero the concentration. So as I mentioned, this is the constant fraction, and we have constant amount of drug is being eliminated. And regarding the rate of drug elimination is directly proportional to the plasma concentration. So here the rate of drug elimination proceeds at a fixed rate. T of the drug remain constant irrespective of dose. Okay, that is like 50% because of the constant fraction. And T of the drug is not constant. Okay. So if the falling plasma concentration is plotted against time, the resultant plasma followed curve will be curvilinear. But if the logarithms of a plasma concentration are plotted against time, the resultant plasma followed curve will be linear. Normally, the fact is that you have to follow this only because normally means in the log transform curve is being used in the pharmacokinetics. So here in this case, the opposite is being seen. The plasma followed curve is steeply linear, but if the logarithms of the plasma concentration are plotted against time, resultant plasma followed curve becomes curvilinear. Just like the opposite of first of the concentration. So let's see drugs with zero order kinetics. What are the drugs that is being there? One is the warfarin, aspirin, alcohol, theophylline, phenytoin, omeprazole, cisplatin, fluoxetine. So in this case, these are very old drugs, and as I've mentioned in my previous session, that the company wants drugs which generally follows first of the kinetics. They don't want any drug that to be accumulated in the body. For example, if they have if a person has taken a lot of doses, it should be the drugs should be excreted with with that time period. But if we prepare someone with zero the kinetics, a drug with zero the kinetics, if a patient or if any subject takes the drug in a very high quantity, so that will be there in your body, in the patient's body, and ultimately it may lead to a lot of side effects. So no one wants to want a drug which follows a zero the kinetics at the present day. So let's take an example with the help of a drug, not a drug, but methanol. So methanol follows zero the kinetics. So in the case of methanol ingestion, urgent treatment is necessary. Methanol itself results in sedation, but it's generally non-toxic. The toxicity of methanol is a function of its metabolites. So you can see a lot of metabolites, that formic acid is one of them. Okay. As methanol follows zero the kinetics elimination, it will so with time it will turn into the metabolites. So methanol stays inside your body. Okay, and ultimately, since it's been not eliminated, it not follows first the kinetics, so it will transform into formaldehyde and formic acid with the time. So clinicians can understand that the actual danger lies in the time from ingestion, not the total amount. So whatever amount you have taken, so suppose within the first hour, so it is has not transformed to the this metabolite. So the toxicity of methanol will not be seen. So it's the time that matters, okay, in the case of methanol poisoning. So when ingested at toxic levels, will achieve a higher concentration of the substance within the body over time versus the same amount of substance that uses first order elimination. So if it had been a first order kinetics drugs, you have taken a lot of drugs, then the condition may not be as severe as compared to the methanol poisoning. Uh, Now, one thing is important to remember that formic acid is responsible for majority of the toxicity associated with the methanol. So you can see my previous slide for that. So without competition for alcohol reagent dehydrogenase, which convert this methanol into formic acid and formaldehyde, methanol undergoes zero order metabolism and is thus excreted at a rate of 8.5 milligram to 20 milligram per dl per hour. However, if methanol experiences competitive inhibition because of omeprazole and other drugs, for example ethanol, the metabolism changes to first order and it helps to excrete the methanol outside the body. So that's why it has been given, but ethanol is being not being given because it's very difficult to adjust the amount of ethanol that need to be given to an individual. So in that case, omeprazole is a drug of choice in the case of methanol poisoning. So this is one of the famous paper that has been published in New England Journal of Medicine way back in 2004 four or 5. So here it is mentioned that in case of opiate overdose, the opiate generally follows the first of the kinetics, but due to overdose, it moved to first to zero the kinetics. So why that really happens? Because in the case of overdose, a high concentration of drug may overwhelm the ability of an enzyme to handle a substrate, a process known as saturation. Saturated biologic processes are characterized by transition from a first order to zero order elimination kinetics. This characteristic of zero-order elimination of pharmacokinetics lead to the toxikinetic effects that occur with opioid toxicity and render the traditionally recognized pharmacoPK properties of various opioid formulations largely irrelevant during overdose. A simple example means suppose if I give a like 100 milligram dose of methadone, so there are some enzymes for that for to balance the 100 milligram. So if I take like 1000 milligram, it's just an example. So if I take 1000 milligram, that the enzymes responsible to balance that will not be well sufficient, so that 900 milligram or 800 milligram will be there inside your body. So in that case, it will take a long time for the drug, means, for any opiate to get excreted from the body. That's why it has been said that it moves from first to zero the kinetics, and it is very serious. You may heard about a lot of people have taken opiates in like 2010, 8 or 10, 12 to 12 days in certain part of the US where people are taking these drugs first for as a painkiller, then after that they were addicted to that. So if you are taking a lot of opioids, in that case, the drug will accumulate in the body and it will lead to a lot of adverse events. And one more thing is that, for example, a large quantity overdose may lead to erratic absorption also because of some like benzo formation, and it slows the GI mortality, which prolong the drug absorption. So many things happens when you take opioid in a large quantity. Means it first because of saturation kinetics as well as for the different way it is being absorbed, it the opioids will generally accumulate inside your body and it leads to a lot of adverse events. Two more important things we'll learn in this session. One is elimination rate constant, another is clearance. Okay. So what is elimination rate constant? The formula is like looks like this mass into K, rate of elimination. So we are talking about this K. Okay. We are talking about this K. Consider a first order reaction. So rate of drug elimination as being directly proportional to the amount of drug in the present that is available for elimination. The constant that leads the rate of elimination to the available mass of drug is the elimination rate constant. It expresses rate of drug elimination as a proportion of drug being eliminated per unit time. So that you have to remember. The proportion of drug being eliminated per unit time. It can be also defined as a proportion of the mass of the drug. So some say it is mass of the drug, and some say it is volume of the drug that is being cleared per unit time, or can say that is proportion of mass of the drug that is eliminated per unit time. So let's take an example. A drug A that occupies one compartment, and there is like 100 milligram of the drug present in the patient's body, and the drug is being eliminated at rate of 10 milligram per hour. Okay. So and the rate constant will be zero point 0.1 hour. So this is 10 milligram is like this is the 10 milligram rate of elimination. Okay, that is here I put it, and the mass is 100 milligrams. So the rate, elimination rate constant is zero point 0.1 per hour. So in that case, the 110 per hour. So this is for applies for the drug. Suppose now if I like increases the dose to 200 milligram, the rate of elimination will be like 20 milligram. If 50 milligram, the rate of elimination would be 5 milligram per hour. So it is a constant and is fixed for the drug A. So that is why it is being important to know the elimination rate constant of a drug. So we have read about the half-life. So this, if it means this is a formula, you can see this is the most common formula. T half is equal to 0.6935 K. This is easy to remember also. In defines the association between the T half and the elimination rate constant. So the way both represent the proportion of drug eliminated in a certain period of time. And if you ask me what exactly the difference, here you can see it. Elimination rate constant takes a fixed unit of time and reports the proportion eliminated within the time. Okay, and half-life takes a fixed proportion, that 50%, and reports the amount of time required for that proportion to be eliminated. So little bit of confusing. You can just pause this slide and just try to understand what exactly it means between the elimination rate constant and the half-life. Clearance is another pharmacokinetic parameter used to describe drug elimination. Drug clearance is a pharmacokinetic term for describing drug elimination from the body without identifying the mechanism of the process. Drug clearance considers the entire body as a single drug eliminating system from which many unidentified elimination processes may occur. And it is described in terms of volume of fluid along with the drugs per unit of time. And if you try to understand what if someone asks you about the definition of this clearance, you can say the hypothetical volume of blood or other biological fluid from which the drug is totally and irreversibly removed per unit time. That is more important. The more important is the totally and the irreversibly. Well, there are a number of sources to clearance. The one is the one which mentioned everything is known as systemic clearance, and it's the sum of all individual organ clearance that contribute to the overall elimination of the drug. The clearance based on the organ system, for example, here we have liver and we have renal as well as some bit of metabolic clearance. So here in these organs do the excretion part, okay, and the hepatic clearance, we'll talk about it in my subsequent slide, and there is also called metabolic clearance. It's not so common, but it happens. So that is also, in some cases, you have to take care of while determining the overall clearance of a drug. So let us try to understand about hepatic clearance or excretion ratio. This is not being commonly seen in the PK books, pharmacokinetic books, and not being discussed, and you should know about it because many people have only focused on the renal clearance part. So, for example, this the first one it shows that the blood flowing from the liver, okay, and from left to right, and the blood contains a drug that is being eliminated by the liver. The concentration of drug in blood entering the liver is 50 milligram per ml per liter, and under is 25 milligram per liter. So the in is 50 milligram and 25 milligram is being out. So in this case, C in minus C out, we can say like 50 minus 25, in is 50. So ultimately it is lands at 50%. Excretion ratio is 50%. So what exactly the excretion ratio is? It is the proportion of drug eliminated as blood passes through the liver. The amount removed is different between this is like 25 as I mentioned, and ultimately it's what we have is 50%. So if someone asks you what the excretion ratio of this drug, we will say that it is 50%. That is the 50% of the drug is being metabolized in the liver. So to understand how extraction ratio is associated with the clearance, in that case, clearance is equal to extension ratio into QA. So what exactly is QA? Q is used to indicate blood flow and is specified the hepatic blood flow. Okay, so here if the hepatic blood flow is like 10 liter per minute, and the extraction ratio is like if you see 50 milligram and you can see zero, nothing is coming out. So in that case, it's like 100%. So what clearance is equal to QH? QH here is around 10, and the extension ratio is 100, or you can say 1 in that case. So ultimately clearance is equal to 10 liter per minute. So this is how the clearance of the lever will be calculated in this case. Here it is clearance with partial extraction. Here you can see 50 milligram are moving in, 25 milligram are moving out. So ultimately 50 minus 25 is 25, and the extraction ratio is like 50%. So the 10 into QH is the 10 liter per minute blood flow into 0.5 is equal to 5 liter per minute. So I've highlighted some slides with drugs having high expression ratio. So these drugs are rapidly and extensively cleared from the blood by the liver. Their clearance depends primarily on hepatic blood flow, and binding to blood components is not an obstacle for extraction. The extraction is said to be non-restrictive or blood flow dependent. So these are the drugs that has been seen with high extraction ratio. So a few more examples. First one is low extraction ratio. It depends. It's independent of hepatic blood flow. The other slide we have seen that it is dependent on hepatic blood flow, and here it is dependent on the intrinsic metabolizing capacity of the liver and by the free drug fraction. For example, warfarin and phenytoin. As you have seen low extraction ratio, you can also remember that phenytoin has a very high bioavailability, close to like 90 to 100%. So in this case, since this drug is not being metabolized by the liver, you can expect a very high bioavailability of these drugs. And regarding the intermediate extraction ratio, it depends both on the hepatic blood flow as well as the intrinsic metabolizing capacity. So it is between the high and the low extraction ratio. So a few examples are there, aspirin, like codeine, etc. There is another thing called intrinsic clearance also. I think that you should know about it. It is defined as the hepatic clearance a drug would have if it was not restricted by hepatic blood flow rate. So generally it applies for the intermediate or low expression ratio. It is the ability of a liver to remove drug in the absence of flow limitation and binding to cells or proteins in the blood. So this is all about intrinsic clearance generally, and this is about the systemic clearance. You can see it is renal clearance and non-renal clearance. In non-renal clearance, we have hepatic clearance, we have intrinsic, within hepatic clearance, it may be intrinsic clearance or non-intrinsic clearance, and also in metabolic clearance in case of non-renal. So if you went for a lab test for renal function test, you might have seen creatine clearance. So creatine clearance helps us to identify a healthy kidney. So creatine is an endogenous metabolite, and the way it is excreted helps us to understand the status of the kidney. So creatine clearance is something like that. This type of renal clearance and applied to endogenous creatine. It is used to monitor renal function and is a valuable parameter calculating the dosage regimens in elderly patients or those suffering from renal dysfunctions. These are some creatine clearance values in males and females. Slight variations are there. For example, this why it is important because some drugs which have been renally excreted in those patients, in the patients in which you prescribe these drugs, in that case, this patient should go for renal function test to evaluate the creatine clearance because these drugs are renally excreted. So if there is a high creatine clearance, if the creatine level is high, in this case, if you have a problem in the kidney, this drug will be not excreted. Okay, so it will be accumulated inside your body and it will be toxic both for the kidney as well as for the body. So in that case, you have to go for a renal function test to understand the status of the kidney, and this can be done easily through by estimating creatine clearance. These are my references. Please like, share, and subscribe my channel if you like the presentation. In the next session, we will discuss on the different graph of oral and IV route of administration. Till then, bye.